Hello, friends. Welcome to Heart Talk, the podcast that's going to be first in your hearts and minds. We're going to tell you about all matters of the heart. We're here broadcasting from the Heart Hospital in Plano, our new sound studio. We have 3 heart hospitals, Plano, Denton, and McKinney. We have a storied history over almost the past 25 years. We want to give you an introduction into the Heart Hospital, into who I am. I'm David Brown, interventional cardiologist, founder of the Heart Hospital, and your host for the podcast of Heart Talk. So welcome. We're glad to have you today. We're going to move into some personal bits about who I am and tell you how we got here.
You're listening to Heart Talk with your host, Dr. David L. Brown. Dr. Brown is an interventional cardiologist, innovator, and co-founder of the Baylor, Scott & White, the Heart Hospitals in Plano, Texas. He now serves as President Emeritus of the Heart Hospital's medical staff. And now, here's your host, Dr. David Brown.
I grew up in a military family. I was in the Army for 19 years. I had a relatively clear path about the military, about business. I was accepted to business school. I knew where I was headed in the Army and in the business world. And then an abrupt change came about in my life. And as a result, I decided to become a cardiologist without knowing what a cardiologist was. And quite frankly, without knowing what a physician was. Even in the Army, I'd never been on sick call. I'd never been sick a day in my life. I didn't know anything about medicine. I hadn't taken the science courses. But I was pretty sure that I was going to be a cardiologist. Just I had to explain that to the medical schools to make sure that I could go to medical school. So we did that, went to medical school, and then trained in the Army. I trained at Walter Reed Army Medical Center in Washington, D.C. There, we were doing internal medicine, and we established the first coronary care unit at Walter Reed Army Medical Center at the time. Coronary care units were just discovered or established in the 1960s. Before, it had just been an ICU. And people presuming or wanting to be a cardiologist were really internists. And they were just sort of glorified internists who label themselves as a cardiology because they either liked the heart or could say heart or were determined they were going to be a specialist who only did heart. But there was no formal training for it initially. That ultimately developed, and we started training cardiologists. So wanting to be a cardiologist, I came out of Walter Reed to do that and trained in cardiology. When I first started, the first coronary bypass surgery had only been done in the late 1960s. We were now in the 70s. We had started doing this thing called heart catheterization, sticking a catheter into your heart through either your arm or your leg. 2 physicians started those 2 things, Mason Sones and Mel Judkins. And so we had 2 techniques that we used. But fundamentally, you had to be really sick for us to go treat that with anything interventional at the time. Bypass surgery was there, but in terms of having 3 arteries and a left main artery, if you didn't have high degree blockage in your left main and high degree blockage in your right or severe 3 vessel disease, you didn't get to go to bypass surgery. And even if you did get to go to bypass surgery, we often had to talk the patient into it because it would explain the risks, the likelihood of dying. And it didn't sound good. So in the meantime, we were just glorified internists. We had aspirin, we had beta blockers, we had some calcium antagonists, and we'd give you some drugs. If you had a heart attack, even at a young age, you came into our hospital and we put you in our brand new coronary care unit. And if you lived for 7 days taking our medicines, we would move you out to the floor and say, okay, do good, be good. If you're still here in a week, we'll let you go home. So we didn't really do anything interventionally. What you've seen in the world over the past half century is the development of interventional cardiology. And as a result of that, we went through heart catheterization, and in the late 1970s in Zurich, Switzerland, Andreas Grunzig performed the first balloon angioplasty by putting a balloon in someone's heart. This was the change of all the people my age as we were pioneers in cardiology trying to figure out what we could do. But for the first time, we had the ability to go treat somebody with high-grade blockage in their heart without cutting their chest open. It wasn't error-free, and it wasn't low risk. And there were different problems with it, sometimes things like abrupt closure and other things that led to emergency surgery and the complications of us having to arrange to have surgeons on standby and have them be on call, sitting in the ante room waiting for us, to see if we could get it done without screwing up. This also led to a whole degree of tension across the country between surgeons and cardiologists, as well as other colleagues whenever there were complications of, maybe you shouldn't be doing this. But as you've seen, and today, coronary stenting is done across the world, and it's done as a low-risk procedure, a minimally invasive procedure that fundamentally can change the way heart disease has as its outcomes, and can get to a point where we even do this in places where you don't necessarily have to have a surgeon. So the entire atmosphere has changed about how we treat hearts. But back then, we were trying to grow this, and we were using balloon angioplasties after Andreas Gruenzig did this. Fast forward another 10 years, and the first coronary stent is placed in 1987 by Gary Rubin, and this goes on to get the first coronary stent approved in 1993. And during this period of time, cardiologists are becoming incredibly involved in procedure-based medicine. Before, we had been office-based physicians. The surgeons were doing very narrow perspective heart surgery because you had to have this element that fit right in the center of the fairway to be able to go to surgery. As a result, the tension we talked about mounted between surgeons and cardiologists. And in the mid-1980s, I left the Army and went into private practice. We had trained, both myself, many colleagues, and surgical friends who I ultimately met. We trained in academic centers. We trained in university centers where we saw this composite of complicated corporate bureaucracy in healthcare, in the treatment of patients, in everything including research, education, and training. And there were a group of us that didn't want to do that. We wanted to be able to forge our own path, to build our own direction about how to treat patients with this burgeoning field of interventional cardiology. When I left the Army, I had the good fortune to make friends with, become colleagues with, become professional partners, if you will, with two heart surgeons who have, over almost the last half century, become two of my closest friends, two of my best friends, and two partners who have helped us get to where we are today. So if you take that part, we then spent a period of time trying to figure out how we can build what we wanted to do in research, in treating patients, and building the best cardiovascular unit that we could have without it being bogged down with bureaucracy. About this time, in the 1990s, corporate America was starting to get involved in and take over healthcare. As they did, especially in urban centers and cities, hospitals were being bought up, corporations were being developed, bureaucracy was coming in. We were losing control of even simple things like peer review, quality in the outcomes of cardiovascular medicine and surgery and cardiology, and even our ability to interface with industry as all these devices were being developed. So around the turn of the century, we had tried to have a couple of ventures to work through this, including building one of the first freestanding outpatient cath labs, including building centers for cardiovascular PET scanning and other things. But they were fought by the hospitals in a way that we were never going to be successful. So there was this sort of fantasy that developed, almost this dream of, can we build a hospital that's just a heart hospital? Can we build something where we can go and do what we do best and do it with the least interference that we can possibly have, and have a say in everything that's done in a hospital, including how it's built, the infrastructure, the people that work there, the quality of nurses, the quality of people that we hire, the quality of everybody from valet to food services to respiratory services to therapeutics and pharmacy and all the parts and pieces. And quite frankly, I'm not sure that we knew we could do it, but it was a little bit of where there's a will, there's a way. And I started putting pieces together and inviting people to come together to try to build this. At the time, there were some places in the country that were called heart hospitals or heart institutes, more heart institutes that had been around maybe for 100 years, but just a few of them. And just at the turn of the century, the idea of cardiovascular care becoming more of an isolated entity unto itself started to develop. And in this same aspect of controlling your own destiny and controlling your future, several hospitals that could be controlled by physicians, even with physician ownership, came into being. But it was a very complicated time. It was a very complicated vehicle. We actually had several efforts, including an idea that we developed into the first freestanding outpatient cardiac catheterization lab in North Texas or all of Texas at the time. And it was an ideal model. It was essentially building this cath lab that had the highest level concierge service, the highest level infrastructure. It literally looked like you were going to, what we referred to as the luxury hotel to get your heart catheterization. The service you got was the same thing. And we did it with one of our hospital partners. What we didn't know at the time was the level of tension that existed between these hospitals and physicians in their view, to the point where effectively this thing was doomed. It was never going to have longevity. Whether it always had intent to be sabotaged, hard to say, but it wasn't going to last and it didn't work. That was somewhat defeating. It felt bad, but it sent us back several steps and back to the starting blocks. Several things happened to me personally, even health-wise and other things that put this on pause as the century turned. But at that point in time, there were several heart hospital concepts coming out of the box, trying to build what we had been looking for a decade or more. It was a difficult concept, and at the time it was just a figment of imagination. Didn't really understand how you're going to piece this together. It required time, a lot of time, while you're practicing in busy cardiology and cardiac surgery practices. It required money, financing, a little bit of legal, a little bit of healthcare lawyering, accounting, keeping track of any money you could find, and even on into the idea of now you're going to become a real estate agent. You got to find some land. You need a little bit of architecture. We had this idea we were going to build this. In the past, it had been a cath lab, an outpatient cath lab, and people were starting to put together diagnostic spaces and figured out what we really needed was a freestanding, independent heart hospital that we controlled and we ran with all those things of a seemingly insurmountable mountain. And as some of you know, after the turn of the century, one day I received a cold call letter from a consultant who used to be a GE consultant, an executive with GE, who had gone out on his own and was now a consultant for cardiovascular health care, and sent me a letter saying, We can help you build a heart hospital that you control and you run, and you can do all the things that you're trying to do. And it was literally like manna from heaven. It was like, how can this be? I had one of our assistants get him down to Dallas immediately. We met, we talked about it. And in less than a month, we evolved a concept that this was a possible idea, a possible program that we could bring to development. So starting from nothing, we wrote a letter to 120 colleagues, cold call letter for them. This train's leaving the station. If you want to be part of the future of cardiovascular care, you need to get on this train. There is one meeting and one opportunity to join this. You need to come hear about it. And if you don't, you miss the train. 120 letters, 93 came. 93 wrote checks that we told them, more likely than not, you're going to lose that money. We're going to win with the simple motto, the simple concept that quality wins. We are going to drive this to the highest level of cardiovascular care that you can possibly have. So we set off on this journey. We had a meeting in our great room for the first meeting, and then sequentially decided that we needed to meet every 3 weeks, and did every Thursday, 6 p.m., come rain or shine. With that, we set off, and I did practice law, accounting, financing, real estate management, real estate acquisition, healthcare, lawyer understanding, moving through things like Stark and anti-kickback statutes, looking for architects, looking at concepts of how hospitals are built, looking at hospitals across the country, talking to people. I went on fishing trips just because I knew there were people on those trips who were in the same process of trying to develop heart hospitals, or were at the edge of getting a heart hospital built or developed. I didn't even like to fish, but I went on these trips, and those things helped us formulate what we were doing. So over the next 6 months or so, we started putting this together and understood that the success of this was going to rest on the idea that we built a critical mass of physicians that could be independent in this market. Otherwise, we would fall into the same trap we've been in, where you're at the mercy of hospitals, of an academic center, of a university, of things that you really can't control. What I also knew was that, having looked at a number of these vehicles being developed, it was a very difficult process to fight off all the hospitals and all the hospital systems in any market, especially the market like DFW, the Metroplex. There were 3 or 4 powerful hospital systems. At the beginning, I didn't tell my partners that we were likely to, or probably would, or definitely would, wind up with a partner who understood who we were, what we were trying to do, and left us with control. But that was the intent. So I set off on a journey, talking to and interviewing these hospital systems with the attorney that I hired from Indianapolis, Terry Heath, and his firm Hall Render, who was a healthcare firm only out of Indianapolis. And with Terry, we went through the process, understanding who could possibly be the best physician-friendly partner. At the end of the day, I'll tell you, it turned out to be Baylor, now Baylor Scott and White Healthcare. And I'm going to name some names because without these 3 people, we wouldn't be here today. But through Gary Brock, Senior Vice President and Executive of the Baylor Healthcare System for Mergers and Acquisitions, the General Counsel at the time, John Thomas, and the CEO, Joel Allison, we couldn't have gotten this done. We did raise the money. We could raise a lot of money. We could do a lot of things. And we probably or possibly could have gotten it done. But I don't know if it would have lasted. I don't know if the longevity would have been there. And just to make it a little more interesting, right in the middle of this process, the federal government decides we really don't like physician-owned hospitals. Only corporations should be allowed to own hospitals. Physicians should not be allowed to own hospitals because they'll take unfair advantage of it. We believe that this was more about being the best physician and delivering the best quality and not taking advantage of some system or worrying about how you were going to get paid. We believe that if we were the best there was, everything else, including money, would take care of itself. The federal government passed an 18-month moratorium banning all physician-owned hospitals. The development of them, the use of them, even the ones that had just been completed and were being used, and it just threw a monkey wrench into the entire thing. At the time, there were 7 other projects in development to be heart hospitals across the country. By the time the moratorium expired, and it just had its course where it would expire, because of those 3 people I told you about, Baylor stood beside us, didn't quit, and we were the only one of those 8 that was left. The other 7 folded and never came to be. It seems almost inconceivable today, some of the odds that we face, some of the things that we went up against, and some of the things we probably didn't even understand. There are obviously a few more details mixed into that, but over the course of the next 1 to 2 years, this started coming together, and somewhere between eventually and pretty soon, we realized we were going to have to build a hospital, open a hospital, operate a hospital, and that we needed a team to do that. And we also needed an executive or leadership team to do that. And if we were going to have a team, we needed a leader. At that point, we went on a national recruiting search for the best leader we could find for this heart hospital. That's a story in itself, a story that we will tell you next time in our next episode of Heart Talk. Thank you very much. Thanks for coming today. We'll see you next month.
Views and opinions expressed by Dr. David Brown are his own and do not necessarily reflect the views of the Baylor Scott & White The Heart Hospital or any of its officials. The views expressed by guests are their own, and their appearance on the program does not imply an endorsement of any of them or any entity they represent. The information provided herein is considered educational and should not be used during any medical emergency or for the diagnosis or treatment of any medical condition. A licensed medical professional should be consulted for diagnosis and treatment of any and all medical conditions. Call 911 for all medical emergencies.